thank you very much for the kind invitation to come and your very elegant introduction of me. I'm just a small player in this field, you know. Having heard the previous two speakers with their very exotic and super technical imaging, I'm ashamed to say all I'm going to show you are things that can be seen with the naked eye. Very primitive, I'm sorry. I'm back to the Stone Ages, sorry for that. I'm just going to review AV canal, balanced pathoanatomy. That's my task for today. What is AV canal? To my mind, it represents a whole spectrum of lesions, ranging from things that are called canal defects, endocardial cushion defects, ostium primer matrix septal defects. These malformations are unified by what we describe as a common atrioventricular junction. And I think together with biventricular atrioventricular connections, I know there are some people who will dissent on that, but let's stay with the basics for today. So the atrioventricular junction in a normal heart is characterized by this. A figure of 8 configuration, isn't it? We've got the mitral valve here, tricuspid valve here, looking from the atria down towards the ventricles. We can see tucked into this waist of the figure of 8, the aortic valve. So a very characteristic arrangement of valvar tissues in the middle of the heart. In a heart with atrioventricular septal defect, however, we have a more oval-shaped atrioventricular junction, although that can vary from heart to heart with atrioventricular septal defect. And because of this more oval-shaped atrioventricular junction, we have a more anterior placement of the aortic valve, no longer tucked into the waist of the figure of 8. We see here a heart of atrioventricular septal defect with conjoined bridging leaflets, sort of the superior and inferior bridging leaflets joined together. But on the other hand, we may see one of these atrioventricular septal defects to your more canal kind of concept with bridging leaflets that are not joined together, and you can see through the gap the crest of the ventricular septum, but nonetheless you still recognize that sort of oval-shaped atrioventricular junction with anterior placement of the aorta. So then we can put together a very simplistically diagram showing superior and inferior bridging leaflets. There are actually 5 leaflets making up this common atrioventricular valve, with a common valvar orifice in this form, a so-called common valve orifice with canal malformation, if you like. The important thing, superior bridging and inferior bridging leaflets are not coming together. Whereas, by contrast, your so-called primum kind of atrioventricular septal defect is simply a division of that common valvar orifice by fusion between superior and inferior bridging leaflets. So from the underside then, the atrioventricular septal defect heart will look like this versus a normal heart. We've got the tricuspid and mitral valves, and we've got the aorta tucked in the middle, in between the 2 atrioventricular valves. Whereas in atrioventricular septal defect, we have a more common kind of atrioventricular junction with, as I said, a displaced or originally anteriorly positioned aortic valve. I have to be careful about talking about displacements because Adriana is in this room. The portion of the left atrioventricular valve in atrioventricular septal defect we describe as having 3 leaflets, comprising superior and inferior bridging leaflets and a mural leaflet. And the morphometric studies on pathological specimens showed us that this mural leaflet should be in the ones that have proper valvar orifices, then about 1/5 of that circumference, whereas if you're talking about mitral valve, this leaflet occupies about 2/3 of the circumference. So then, those who are very obsessed with terminology don't use the term mitral valve. Then there's this thing called the cleft in the left atrioventricular valve leaflets. It's simply the gap between the two superior, the bridging leaflets that have come together. There's a little gap there that's more obvious on the left side, so it's called a cleft. We do find it on the right side as well, but somehow people don't pay notice to that, so it's not called a cleft. Now, the extent of superior bridging leaflet in the right ventricle is classified into three types, Rastelli type A, B, and C. Type A meaning that there's little bridging of that superior bridging leaflet into the right ventricle, and the other extreme, type C, much more bridging of that superior bridging leaflet, and this tends to have a free floating kind of arrangement of the superior bridging leaflet. The inferior bridging leaflet in all three types may have varying degrees of attachment to the ventricular septum. Indeed, some of these may actually be plastered down with hardly any interventricular communication underneath the inferior bridging leaflet. And then again, versus the normal situation. In the normal heart, if you measure the inlet to apex dimension versus apex to outlet dimension, it's practically similar. Whereas in atrioventricular septal defect, we would find a disproportion between inlet and outlet lengths, as we show in this pathological specimen. The inlet is shorter, and we tend to have a longer outlet length. We notice also this arrangement when we look from the front of the heart, so there's a narrow kind of winding kind of outflow tract in this situation in atrioventricular septal defect. Now, atrioventricular septal defects also affect the levels of shunting within the heart, depending on the arrangement of the bridging leaflets. So we've got these like whiskers, actually, they represent bridging leaflets. Superior bridging, inferior bridging leaflet attached to the crest of a ventricular septum, so leaving potential only for atrial shunting. When you have both leaflets that are lifted off from the crest of the septum, you can have both atrial and ventricular shunting. And this is a rarer form, at least in the pathologic series, where there's only the potential for ventricular shunting because the leaflets are hinged more to the underside of the atrial septum. And this, Adri has alluded to previously, that diagnostically, when we train sonographers, we would say, well, look for this offset arrangement between tricuspid and mitral valve. That would tell you you're possibly looking at a normal four-chamber view, whereas if you have loss of offset, then you're possibly looking at something like an atrioventricular septal defect. But be careful, because as you go deeper down into the more basal part of the heart, more towards the coronary sinus orifice, you may get a situation where you do see an offset arrangement between the left and the right atrioventricular valves. The level of shunting, examples of those so-called ostium primum kind of defects with interatrial communications only, we can see on the right side here the plastering down of the superior and inferior bridging leaflets, leaving a hole at atrial level, sort of above the surfaces, atrial surfaces of the valvular leaflets, and also on the left ventricular side. By contrast, the leaflets are sort of attached by chordae to the ventricular septum, and they're free floating, the so-called canal kind of configuration. You get potential for shunting at both atrial and ventricular levels. And this is a so-called intermediate or transitional type, whereby there is fusion between superior and inferior bridging leaflets, but it's not an ostium primum type of configuration, because you have not only an interatrial hole here, you also have an interventricular hole underneath the level of the leaflets. This is seen from the right side, and here from the left side, interatrial, interventricular levels of shunting. And then the third type, where the leaflets are attached not only to the common valvular junction, but also to the underside of the atrial septum, giving you potential, when the leaflets close up together, giving you the potential only for interventricular shunting. In this particular form, I must say that oval-shaped kind of atrioventricular junction that we commonly associate with atrioventricular septal defects, that oval shape has a little bit of a wasting at the atrioventricular junction, septal part. So to summarize diagrams of various levels of shunting. And now I'd just like to comment briefly on some features that are relevant to surgery. With regard to the atrioventricular node disposition, as Adriana has mentioned, the atrioventricular node is not in the regular expected position as we would find for a normally septated heart. It's not at the apex of triangle of Koch, because if it's there, there's no way, there's a gap here, there's no way for the atrioventricular conduction bundle to get down to the ventricular structures. So instead, the atrioventricular node is sitting here, in between where the ventricular septum comes up to the atrioventricular junction and where the atrial septum comes down. So the location is then determined by the annulus of the inferior bridging leaflet and the orifice of the coronary sinus, so in between there. And the same disposition, whether you have only atrial component of shunting, or both atrial and ventricular, or only the ventricular component of shunting, exactly the same position for the atrioventricular node. But beware, you may have two AV nodes, especially in those where the right ventricle is on the unexpected side of the heart, and the left ventricle is on the right side, right ventricle on the left side, for example, usually in association with isomeric arrangement of the atrial appendages. But for the more usual form, we see here the node sitting close to the orifice, atrioventricular septal defect, according to the criteria of having an oval-shaped atrioventricular junction and short inlet, long outlet lengths. So an atrioventricular septal defect, transilluminated, but without any holes at all, intact cardiac septal structures. So I think the constants are, for me, biventricular atrioventricular connections, a common atrioventricular junction, and inlet-outlet disproportion. Thank you very much.